Thank you, Chairman, and ladies and gentlemen. I'd like to thank the organizers for asking me to come and talk today. So I have nothing to disclose, but I will overlap with the previous speaker on one or two things. But let's just go back to pregnancy, because although we've had a description of the physiological changes in the mother, which may indeed cause goiter as well as physiological changes, it is in fact the neurobiology of fetal brain development which we are interested in, because we know that, as has been said, T4 transports across the placenta, and that the baby is dependent on maternal T4 for a good deal of the pregnancy, 16 to 20 weeks. And so the T4 delivery to the fetal neurons is critical, and this depends on maternal iodide supply, maternal T4 synthesis, the T4 placental transport, and T4 to T3 conversion, and there's a role for the thyroid hormone transporters there. And we know that TSH receptor development in brain occurs very early in gestation, and we have observed thyroid hormone effects on genes related to neurodevelopment, for example, myelin, and so it's a very temporal process. And in pregnancy as well, we shouldn't forget the immune system changes characterized by the development of a Th2 type cytokine profile and involvement also of the Th17 immune regulatory system. This slide shows just a glimpse of the perhaps complexity of T4 transport into the different neuronal cells, and illustrates, for instance, that as far as the astrocyte is concerned, it's probably dependent on one type of transporter, the OAT-P1C1, and conversion of T4 to T3. Whereas to get into the neuron, there's perhaps a different approach, and that more depends on the MCT8 transporter. And then the oligodendrocyte, again, perhaps uses other transporters. So this is an active field of research and is very important. And one interesting thing is that we don't understand placental function when there's too little thyroxine in the mother. Why doesn't the placenta allow more thyroxine in? Another aspect of temporal process of brain development in utero is illustrated here from a review by Williams, and it shows the different aspects of the brain over pregnancy and even into the neonatal time. And it shows that the development occurring at different times, so that one can imagine that abnormalities in thyroxine transport may affect different structures at different times. So just a revision of some facts and figures, we know that hyperthyroidism occurs in about 2.2%, whereas hypothyroidism, as has been described, perhaps 2 to 2.5%, mostly subclinical, but overt, perhaps 0.5%, and we might come back to the overt later. Thyroid antibodies, mainly TPO, around 10%. And then we shouldn't forget the postpartum period, because postpartum thyroid disease is about 5 to 9%, with postpartum depressive symptomatology having been documented in around 30% versus 20% of controls, and an occurrence of postpartum Graves' disease in ladies, really a high proportion of Graves' disease occurring in women. So if we can just deal with hyperthyroidism, because that has an effect on both the mother, as has been documented, on the miscarriage, on the fetus, and on the neonate, as you can see there, in untreated or inadequately treated hyperthyroidism. There are side effects of antithyroid drugs, and they may cause hypothyroidism and goiter to the fetus, as is well known, and we'll come back to the antithyroid drug effects in a minute. And you may get transient hyperthyroidism in the neonate. What about surgery and thyroxine therapy? Well, again, the mother may be hypothyroid. The fetus may be hyperthyroid because of the continuing existence of receptor antibodies, and this may appear in the neonate as well. In a radioiodine-treated mother on thyroxine, a similar scenario may occur, and many of the cases of neonatal hyperthyroidism seen in hospitals are are allowed to happen because of the non-realization of the propensity for thyroid receptor antibodies to continue in surgical or radioiodine-treated women. And previous antithyroid drugs, well, the lady may relapse and cause problems that way. Now, you'll be aware of the problems with antithyroid drugs giving rise to the so-called carbimazole, methimazole embryopathy. But this very large study from Denmark has indicated that PTU may also cause defects. And hitherto, we've been recommending PTU in the first trimester and not really appreciated these defects. And it's because this Danish regular study had such a large number that we were able to more confidently express these, the number of these defects. And what they've been able to do under the guise of Peter Larberg is to indicate a maximal period of sensitivity to teratogens, such as carbimazole, methimazole, and propylthiouracil. So you can see that the malformation may occur during this time period of pregnancy. And further on, a functional disturbance of the fetus may also occur. So that has caused them, and I think we should reflect on this, to propose measures to reduce the number and severity of antithyroid drug-associated birth defects. And so we want to restrict the use in the first trimester as much as possible, give the written instructions to the fertile women to perform a pregnancy test within a few days after the first day of a missed period, if pregnancy is a possibility, and contact the physician immediately. And if she's considered in remission, perhaps lay off the antithyroid drugs with weekly thyroid function testing. But on balance, if an antithyroid drug is recommended, then it probably should be propylthiouracil. And consider the shifts from the thionamides, well, from methimazole, carbimazole to propylthiouracil before pregnancy. Now, these are not set in stone, but these are proposals based on some very good work from Denmark. And included in that are the consideration of surgical therapy in young women with severe Graves' disease because their thyroid receptor antibodies decrease quite quickly. So let's move on after that to the consequences of overt hypothyroidism. Now, the early studies in overt hypothyroidism showed a high perinatal mortality and congenital malformation, with a lot of survivors with impaired mental and physical development. And these mothers were probably not treated. Even later studies showed significant perinatal mortality and small for gestational age infants. And we know what the consequences of severe iodine deficiency are, as illustrated by this classic Swiss lady taken from a print in 1817 with mental impairment and a huge goiter. I just parenthetically remind everybody that, of course, the WHO indicated that we need 250 micrograms intake for both the pregnant and lactating woman. And that if this is not achieved, as shown by a study from the UK, you can get a progressive decrease in verbal IQ and reading efficiency and reading comprehension. So this is even in mild iodine deficiency, but it does seem to correlate with the degree of iodine deficiency. Moving on to the baby, this is a recent epidemiological study showing that if you look at the standardized TSH and the standardized free T4, that birth weight seems to fall quite significantly with the higher end values. And this is interesting, especially in relation to the high free T4, because we, during the treatment of hyperthyroidism, we usually suggest that free T4 is kept to a high level. Now, The previous speaker has already alluded to TPO antibodies and pregnancy causing miscarriage, but it also causes progression of hypothyroidism. There's an increased incidence of preterm delivery. Data have been published some time ago now showing evidence of impaired child development, although the studies that were done then were in very young babies, and one questions the validity and the reliability of studies in the very, very young. We showed many years ago that TPO antibodies are predictive of postpartum thyroid disease. So as has been said, if the TSH is more than 2.5, we believe you should treat with thyroxine. And I know you've seen this slide already, and I apologize, but it just recapitulates the forest plots for the miscarriage here, showing a significant increase, and also the preterm delivery here showing a similar relative risk of TPO antibodies. In fact, from this Chinese study published recently, when they tried to determine the degree of hypothyroidism, so there's a difference between isolated thyroid autoimmunity, TAI here, and subclinical hypothyroidism with more severe thyroid autoimmunity, and you can see the progressive increase in odds ratio in terms of miscarriage. So I think there's no doubt that the more hypothyroid you are, the more chance you have of developing a miscarriage. And this was a prospective cohort studies. Now the interest, of course, is in subclinical hypothyroidism and isolated maternal hypothyroxinemia and neurodevelopment. And I've summarized here some studies which, on the one hand, in the top bracket here, indicate that subclinical hypothyroidism does indeed have effects on neurodevelopment with impaired visual development, neurodevelopmental delay, and behavioral problems. On the other hand, there are some studies which show no effect, and some have some faults in the study, some don't, but some are on cord blood, some are on premature infants, but they have to be taken into account, and it does raise the question that I've talked about before, namely the type of psychological testing that is done and the age of the child when this is performed. However, there have been more recent associations with high TSH, so seizures, autism, and attention deficit hyperactivity disorder, and also, again, more preterm delivery, gestational hypertension, and pre-labor ruptured membranes have all been documented relatively recently. And here we have, just as an example, a study published, well, almost 2 years ago now, but looking at gestational maternal hypothyroxinemia and the increased risk of autism. And here you see the score relating to autism, and in the red bars, you see that they have a much higher score, which indicates an increased likelihood of development of autism risk. So, and more recently, there have been studies tending to confirm A, autism, and B, attention deficit hyperactivity disorder. Now, maternal hypothyroxinemia and impaired neurodevelopment has actually been observed many years ago by Evelyn Mann, and she noted developmental deficit as early as 8 months and lower psychological scores when the children were between 4 and 7. And when she treated sibling sets, the outcome seemed to be better. But in those days, the socioeconomic confounding factors and the sophistication of analysis was not generally employed, and so these data were not seized upon, as it were. But more recently, we have had data to suggest that maternal thyroxinemia does seem to be associated with impaired neurodevelopment. Of course, some people say, well, is maternal hypothyroxinemia a disease at all? And it depends how you develop it. Should it be in the bottom 2.5, as many of us feel, or the bottom 5th, as some workers have done, or the bottom 10th? This has not really been decided. But as you can see from these examples, we have expressive language delay, lower mental scores in 2-year-old infants of women in the bottom 5th percentile, children aged 5 to 6, and that's a good age for doing psychological and neurocognitive testing, with a poor performance in simple reaction time tests, and children even older than that scoring lower than from normothyroxinemic mothers. But then you go back to preterm infants with poorer cognitive performance, but at 5.5 years, and I've already alluded to the quite substantial increase in incidence of autistic symptoms in 6-year-olds. So I would submit that this body of evidence, observational though it is, does add to the view that maternal hypothyroxinemia should be taken seriously. So what can we conclude about the neurocognitive effects of maternal hypothyroidism and hypothyroxinemia? Well, both these conditions have shown lower full-scale IQ scores and reduced performance in motor skills, and increased reaction time, as I've said. In addition, maternal hypothyroxinemia has shown evidence of poor psychomotor development and delays in expressive language and cognition, and I keep coming back to the autism. So I think that the current data do suggest an increase in pregnancy loss, gestational diabetes and hypertension, preeclampsia and preterm delivery in women with subclinical hypothyroidism. But perhaps the association between subclinical hypothyroidism and impaired neuropsychological development is somewhat inconsistent. And maternal hypothyroxinemia, on the other hand, does seem to be associated with impaired neuropsychological development of the offspring. And these were our conclusions in the guidelines that we drew up for the European Thyroid Association and published in the European Thyroid Journal last year. Now, of course, all these studies have been observational. So in the year 2000-2001, we undertook a randomized controlled trial to see whether, in fact, the strategy of screening for thyroid dysfunction and treating women with either subclinical hypothyroidism or hypothyroxinemia would be effective in altering the development of the child when assessed about 3.5 years. So we did a prospective randomized trial. We recruited about 22,000 singleton pregnant women, and we tested the primary outcome, which was the IQ between 3 and 3.5 years old in the children. And we looked at stratification and compliance with therapy. And suffice it to say, in this randomized trial, antenatal screening at a median gestational age, and this is important, of 12 weeks, 3 days, and treatment for hypothyroidism did not result in improved cognitive function in the children aged 3 years, although there was a little bit of uncertainty about it at the time. So what are the possible reasons? Because I've already suggested that there's quite a lot of observational evidence for impaired neurodevelopment. Well, the timing of the screening might be one thing. It was rather late, and if you refer back to the cartoon I talked about with brain development, it may have been too late. There was mild hypothyroidism in both groups, nearly a 50% low T4 and normal TSH, and there was no information on the IQ in the normal population. The study was adequately powered for both those with just high TSH and those just with low T4. But then you come to think about the testing and the specificity of cognitive impairment in thyroid-deficient children. and I've talked about expressive language delay and orientation decrement and so on. And it may be that our testing wasn't specific enough. It was a rather generalized but valid and reliable test. And our TSH levels at inclusion of our study was above the 97.5th centile, quite a lot, compared to the previous study in the New England, a retrospective published by Haddo in 1999, which looked at the 99.7th percentile and TSH above there. And there may be other reasons which we haven't come to. So the exciting thing now is to think about neuroimaging of these children. And this is a study published a few years ago by Joanne Rivette showing alterations in hippocampal volume in children whose mothers had hypothyroidism in pregnancy and was inadequately treated. And she's just published another study showing corpus callosum abnormalities in similar groups. So I think this is one way forward to at least document the neuroanatomy. Now, screening has been mentioned, but I just thought it would be useful to remind you of the justification for a screening test. And I'm not going to read out all these, but you can see that they're fairly logical. And what I would submit, if you put maternal thyroid disease into these paradigms, that the answer to the questions and the statements is a yes, all round. And that is exemplified by the frequency of the hypothyroidism, the effects on the mother and the child, and the effectiveness of screening strategies and of intervention, albeit that there is no real positive RCT evidence. And just, I know this has been discovered, but the ATA, there's not enough evidence. The Endocrine Society, no agreement. Some of us sat on the fence. Some of us wanted screening. Some of us didn't. And all strongly supported aggressive case finding. And some of the criteria for that have been illustrated by Dr. Bollard. But there are at least 3 or 4 or more papers that if you do that strategy, you could miss up to 65% of undiagnosed thyroid dysfunction. So that is something which we have to ponder, and a lot of clinics have been pondering it, and it means that screening is actually starting in many countries. So in conclusion, Mr. Chairman, thyroid antibodies are associated with miscarriage and preterm delivery. Subclinical hypothyroidism and hypothyroxinemia are associated with adverse mental effects during gestation, adverse fetal effects during gestation, neurocognitive effects, and the problem about screening is, as we have seen, still controversial. Thank you.